neurological disorder. I would like to call upon Dr. Muridhar Sharma sir, Professor Emeritus, Department of Shalatantra, SDMC Udupi to take over the session. Welcome sir.
In the last session, we had discussed about the examination of the sensory nervous system and certain of the important parts. Now, the next is about the motor system, examination of the motor system. Among the examination of the motor system, the first thing starts with the examination of the muscles trophy or growth of the muscles or appearance of the muscles. Appearance of the muscles could be altered due to many neurological conditions, and the commonest varieties are about the patients who have atrophy of the muscles. Atrophy of the muscles could be produced due to disconnection with the nerve conductions either at the spinal level or at the lower motor neuron level. Now, based upon that, the atrophy types could be of two types, like where there could be a real reduction in the size of the muscles. As you see in this picture, the muscles may become softer and the size of the bulk of the muscles could be reduced. Or the other, that's what we call as a type 1 atrophy, which is more common. Type 2 atrophy is where there could be a bulky appearance of the muscle body, whereas the tendinous area would become atrophied, thin as such. This is what we call as the type 2 atrophy. About that, when the type 1 would occur and the type 2 occur, we will be discussing in detail when we discuss about the spinal cord injuries later on. So, the shape of the muscles could be altered, or there could be the muscular dystrophies. Now, this has to be differentiated from the muscular dystrophy, that type 2 atrophy, muscular atrophy, due to neurological condition, and the type 2 atrophy, muscular dystrophy produced due to pathology of the muscles. These have to be differentiated. In the pathology of the muscles, there could be a bulky muscle, and that bulk could be continuing up to the tendinous area. Whereas in case of the spinal cord pathology induced atrophies, the atrophy more is seen in the tendinous area, whereas the body of the muscle may show a bulging, or majority of the conditions it could be atrophy as such. Or there could be the other sorts, muscular dystrophies could occur also due to neurological conditions, or dystrophy of different sorts could occur, which has to be seen by looking at the appearance of the muscles. You can make out that. Then the next is about the muscle tone, assessing the muscle tone. Assessing the muscle tone is defined as a state of partial contraction in the resting condition. Now, this is a mechanism of the reflex mechanism which keeps the muscles ready for action. See, when a muscle has many intrafusal fibers, hundreds of intrafusal fibers, it's not that when we say the muscle is relaxed, it's not that all the fibers are relaxed. A few of the fibers are kept at a contracted stage to keep the muscles ready for an action within a short time. This is a normal physiology, and this is what we call as the tone. Tone is a state of partial contraction of the muscle fibers at the rest, otherwise visibly resting state as such. Now, the abnormal muscle tone can be felt by feeling the resistance over the muscle body. If you press upon the muscle body, the resistance felt by your hand can be felt as the muscle tone as such. Muscle tone could be, abnormalities could be either there could be flaccidity, it may become softer where it's a hypotonic, or there could be a spasticity, which you call as a hypertonic. The hypertonic muscles where the muscles becomes harder, stiff as such, and many times the muscles may give a shape to the body, like in a typical, particularly in children, pediatric conditions. The hypertonicity may give a specific shape of the body where the muscles become rigid and the whole body may be in an extended condition. Whereas a flaccidity, when the muscles are flaccid or hypotonic, the body of the child may not be able to maintain the position, and it may just get bent as such, as you see in this picture. Like. So, assessment of this spasticity and rigidity, these are the two important variations which can again occur in case of the increased tone conditions. When the muscles become hypertonic, there could be two forms as such, spasticity or the rigidity. The spasticity is felt whenever there is an attempt to move, whereas so if you attempt to move, the muscles become more stiff and the movement may not occur properly, then it's called as a spasticity. Rigidity is even in the resting condition, the resistance is felt as such, and when you see the spasticity, it could be seen in any one direction. In some other direction, the movement becomes normal. Only in some directions, the that increased tone could be felt, or that hardness of the muscles could be felt. Whereas when it's a rigidity, it could be in both the ways. Of course, from Sushruta's point of view or from Ayurvedic point of view, the word Sankochana and Angabhanga, these are the two words which suggest about the Vata Vikara, and Sankochana is about the spasticity, Angabhanga is about the rigidity. Then the flexivity is that condition where the muscles become softer and the muscle tone is not felt. That's the Sambha mentioned in Ayurvedic Samhitas. Then the next is about the muscle strength as such. Now, if usually students do the error of differentiating this muscle tone and the strength. Muscle tone is felt only when in the resting condition by holding the muscle body, and then again see when the patients have to move, see the range of movement or the pattern of the movement, like whether it's a spastic or rigid. When it's a question of muscle strength, you have to press the muscles, make the muscles contract by putting a force on the side of the contractions. Like if you ask you try to plantarly flex the foot and ask the patient to prevent that. Now see how much of the strength is required to plantarly flex or dorsiflex, or similarly with every joint, like you have to have the movements done and see how much of the force is needed to apply, or whether the patient can move that joint movements properly or not. The and muscle strength is usually recorded in the form of a grading from 0 to 4 or 0 to 5. 0 to the 5 grade is where there is a normal movement, and even when you put resistance, even the patient can move against the resistance in all ranges of the movement of that particular joint. Like in a primary this ankle joint, it's a primary plantar flexion and the dorsiflexion. In the knee joint, it again flexion and extension and so on. So in each of the joint, you have to see giving a resistance whether the patient can move or not. If the patient can move against the resistance, then it can be considered as grade 5. And grade 4 is when the patient is able to move against the resistance but not the full range, to a partial range only he is able to move against the resistance. Grade 3 is when the patient is able to move the joint to the full extent, full range of movement, but cannot do it against resistance, without resistance. If you do not press, the patient is able to move, but if you press, if you hold on, cannot do that. And the grade 2 is when the patient is able to move the joint but not to the full motion, full movement, and the resistance of course is not possible, but patient can move the joint if it is not against the gravity. Whereas grade 3 patient can move against the gravity. In the grade 2 patient cannot move against the gravity. Like when it is supported by the gravity, you may be able to see the movement. Muscle contraction in case of grade 1 is muscle contraction is identified, but it is not sufficient to produce the movement. Grade 0 is when there is no muscle contraction seen. So this way, when you assess the muscle strength has to be noted in terms of these numbers which suggest a specific meaning. Then the next is about the involuntary movements. Involuntary movements could be fibrillations, fasciculations, asterixis, tics, myoclonus, dystonias, chorea, ethetosis, hemivalsinus and seizures. What do you mean by this? The fibrillations are not visible to the naked eye except in the tongue. Like see, in other areas you may not be able to see it, but patient may feel that there is some vibratory feeling in some areas. That's what you call as the fibrillations in the skeletal muscles. Fibrillations in a cardiac muscle is a totally different issue. So fibrillation means a rapid fine contractions of the muscles, and in a skeletal muscle it may not be visible, but patient may feel that there is some tremor like feeling. Patient often complains that there is a feeling like there is a rapid movement of the muscles. In the tongue it could be seen occasionally. Whereas the word fasciculation is exactly a similar issue which can be seen over the surface as a quivering of the skin or muscles over the surface of the body. Now you can see these fasciculations could be seen in some of the areas of the muscles. Particularly, they may be seen more in the thicker muscles like the calf muscles. Occasionally, it may not be abnormal, but at times it could be considered as abnormal. Whether it is a normal or abnormal, we will have to confirm based upon the other evidences. So many times, even in the persons who do regular physical exercise, at the end of the exercise, a few fasciculations may be felt at the muscles which are not considered abnormal, but widespread lesions, widespread fasciculations could be suggestive of is a muscle sclerosis, neurological sclerosis due to abnormal conduction of the impulses. More detail about that, how the impulses would produce that different contractions and different types of these abnormal movements, we will discuss later on when we go into the individual diseases as such. Now, at the present, we limit only to the clear-cut meaning of these words as such. Then the word asterixis is a clinical sign that describes the inability to maintain sustained posture with the subsequent brief shock-like involuntary movements. Like if you ask the patient to raise the hand and hold the hands dorsiflexed, with keeping the eyes closed, patient may not be able to sustain it. Within a few seconds, there could be a rapid movement in both the directions. That's called as asterixis. And this also is a neurological sign of improper conduction. What sort of the conduction abnormality, more detail about that we will be discussing later on, which tract is involved and so on when we go into the tract lesions. Then the tics is another of the clinical sign where the patient may have involuntary contractions of any group of muscles or a single muscle, involuntary, and the same is repeated. Of course, tics can occur at anywhere in the body, but more frequently and easily observed is over the face. This it could be like closing of the eyes, lip movements, or so on, any part of the body. It could be in the hands or legs also. Tics could occur, which may be often considered as this habit pattern. Many times it also can lead to some misunderstanding about the personality of the patient as such. But tics are quite common entities. Again, pathological interpretation of the tics is the issue which we will discuss later on. Myoclonus is a jerk of muscle which is a short duration, and it could be like either symmetrical or asymmetrical. Sudden jerky movement of a muscle is called as myoclonus, which also can occur in many disease conditions which we will be discussing later on. Then dystonias are muscle contractions that are more prolonged than myoclonus. So the patient may hold the muscles or a specific part of the body for a longer duration, usually more than 25 seconds. Then it's called as a dystonia. So the word meaning of these words, the exact meaning of these words is an important issue. And most common dystonia which we see is in the neck area, which is easily observed. Elsewhere also it can occur, anywhere it can occur. And in the cervical dystonia, which is common, the majority of the patient may have a dystonia of torticollis, where the neck is turned to a side, and then there could be many these terms used, like when the head is tilted to a side, then it's called as a lateral collis, or when it is tilted forwards, it's anterocollis, and when it is tilted backwards, it's called as a retrocollis. Now these words do not make much difference, but as far as a clinical observation is concerned, you have to observe the position of the body, any part of the body, including neck or maybe the arms also. That has to be observed, and you have to know whether there is a dystonia or not. Ectotosis is another condition where a patient may have a repeated succession of slow writhing movements, movements which tend to like have something like repeated movements which may occur with the twisting of specific parts of the body. Like in a case of hand, you may see these fingers like flexing and then extending, this kind of repeated movement which may have all the sequences, flexion, extension, pronation and supination of the fingers or hands, or at times toes and the feet, and it may be seen as some abnormal behavioral changes as such. That's the ectotosis. A similar abnormal movements may occur with the again repetition which involves multiple joints and may have a appearance like that of a dancing like condition, may be having some evidence or features which look like a meaningful movement, but they are not really meaningful. That's called as a chorea. So the term chorea and athetosis, the difference is athetosis, the movements are writhing movements where you may not have any normal appearance or anything like a normal activity like appearance. Chorea is a something like a dancing movement, which again is involuntary. So it's also a involuntary movement where it looks like that multiple joints are involved and the patient is moving the limbs with certain purpose, but not really with the purpose as such. That's how it's seen, and you have to identify it. And again, as far as the pathological interpretations, we will be discussing that later on. Hemipalestinus is a violent bringing of movement of a half of the body. It could be many times it's often misunderstood as seizures. Seizures where the patient may have impaired consciousness, but in case of hemipalestinus, a half of the body, any one side of the body, may have a rapid jerky movement, which also can occur due to many neurological conditions. Then seizures is where a patient may have a sudden episode of generalized contractions of the body, again which may have a typical stages like initial stage of tone, increased tone where the patient may have a tonic state, the muscles will be contracting, and then there will be a gradual stage of clonic, continuous persistent contractions. A clonic phase could occur. Impaired sensations also could occur. Patient may have a altered sensations at that situation, and that's called as a seizure. Then again the seizure, you may have atypical and typical seizures. The typical seizures would have a typical tonic phase, clonic phase, and a phase of relaxation. When these three phases are not seen, only one or two of these phases are seen, we call it as a atypical seizures. Now that's about the abnormal muscle movements as such. Then comes the examination of the reflexes. Now reflexes are sudden activities which occur without any conscious control as a reaction to stimulus. An activity produced as a reaction to stimulus without conscious effort or conscious interpretation is called as a reflex. Now reflexes could be of three characters: primitive, superficial, and deep tendon reflexes. Primitive reflexes are seen as you see in children. In children, newborn, certain of the reflex activity can be seen quite commonly, and they are usually clapper, tap, rooting, snout, sucking, and palmomental reflexes, which are commonly seen in children. But when the same are seen in the adults, then it could be sign of abnormality of the brain and usually signs of cerebral damage, particularly frontal lobes. Now, superficial reflexes are when you give some cutaneous stimuli like touch or maybe a mild pain sensation, and the these contractions which would occur or the movements of the muscles which would occur are superficial reflexes. Corneal, abdominal, cremasteric, and anal wink reflexes or plantar Babinski reflexes are superficial. Deep tendon reflexes they are produced due to or they are induced by hitting a tendon, making the muscles contract. Tendon is hit to make the muscle contract, and then the reactionary changes where a whole cycle of the reflex contractions of the muscles are observed. That's what's called as deep tendon reflexes. The primitive reflexes are globular tap, like in a child. If you touch the forehead, the eyes will close. If you touch the lip would have a contraction as if it is sucking. Rooting reflexes is if you again touch the tooth, it may look like sucking as such. These are the common reflexes seen in children. But if a similar situation is seen in an adult, then we sign of cerebral damage. Particularly in unconscious patients, we usually do these tests like to see whether the extent of the cerebral damage. Then superficial reflexes are when you touch with the soft object over the eyes. Most common observed reflex is corneal reflex. Corneal reflex is considered to be one of the most sensitive reflex, and particularly under anesthesia, to assess the grade of anesthesia, corneal reflexes are commonly used, or even to assess the exact reactivity of the patient. A patient who doesn't have a corneal reflexes or a corneal reflexes are abolished, then that suggests of a very deep damage or a very significant impairment of the functions as such. So they are considered as the most sensitive reflexes. The assessment of the corneal reflexes is touch the eyeball with a cotton wool or some other soft substance, and immediately there would be winking. The eyes would be closed. If it doesn't get closed, if the eyes do not close as you touch the area, that means the corneal reflexes are abolished. And in any patient where the corneal reflexes are abolished, there is a very highly critical damage to the brain, and outcome can be quite anything like. So you have to be very careful in such conditions. Many times these corneal reflexes also could be used as a sign of death. Like see, for signs of death there are many. One of them would be the corneal reflexes. Of course, more detail about that signs of death, etc. we will be discussing later on when we go into the other. Abdominal reflexes are if you touch the abdominal surface skin with a relatively maybe if you produce a scratch over the abdominal wall with a relatively blunt instrument or maybe with your hand, there would be a reflex contraction of the muscles. The abdominal muscles will contract, and this again would be helping to suggest about the integrity of the thoracic segments, particularly thoracic lower segments like T8 to T12 segments, and these could be studied under all the segments of the abdomen, upper and lower part of the abdomen, both on left and right side, and that could be the assessing the integrity of the reflex activity at the lower thoracic segments. More detail about that, how these would be understood, we will be discussing when we go into the spinal cord injuries and spinal cord pathologies. Cremasteric reflex is when you touch the upper surface of the scrotum with any blunt object, the muscles, dartos muscles will be contracting, and the contraction can be visible. The testicle will be pulled upwards. That's the cremasteric reflex. That's how it has basis. Anal wing reflexes are if you touch the anal opening area with a relatively blunt or sharp, slightly sharp object, there will be immediate contraction of the anal muscles. The anal sphincter would be closed, and this can be seen as such, and that's anal wing reflexes. Or it could be even the plantar reflexes, very commonly observed. Babinski, this also is called as Babinski reflexes. When you touch the plantar surface and scratch over from the posterior side to the upper side, there would be a normal plantar flexion of the toes. The toes will be plantar flexed, which is common in normal. In children, there could be an extension reflex, or it could be an abnormal, and there is an extension reflex. When you scratch the under surface, the plantar surface with a relatively blunt object in a shape, curved shape as such, in a normal situation, there would be a plantar flexion of the toes. But in abnormal conditions, which is also called as Babinski positive, which is suggestive of an upper motor neuron pathology, and again more about that we will be discussing later on. And then it's called as a positive in adults. In children, a dorsiflexion is a normal phenomena. So that's about the superficial reflexes. Deep tendon reflexes are when you hit the tendon with a tendon hammer, it is basis, and it could be like any of the muscles could be examined, but commonly the most frequently examined tendon reflexes are biceps reflex, where you hit on the biceps muscle and see whether the arms will be contracting or not. In a normal situation, there will be a smooth single contraction of the muscles. Abnormality could be any of that variations. Either there could be loss of reflexes, or there could be exaggerated reflexes, or it also can result in a clonus. Repeated pendular movements could occur. So any of the abnormalities could occur in deep tendon reflexes. It may be studied in each of the muscles like triceps or Achilles patellar. These are the very common tendon reflexes which are elicited in the clinical examination. It can be applied to, the same method can be applied to other muscles too, and they can be examined like. Now, the reflexes are usually, when they are studied, they are usually noted in the form of either absent or very mild or just elicitable, or low response or moderately low. Normal is when there is a smooth contraction, and either exaggerated abnormality could be either a brisk, very brisk, or there could be exhaustible clonus, a clonus which is for a few seconds or 2 or 3 movements, then again stops, or continuous clonus, and they could be noted in terms of the numbers, like 0 is normal, minus categories, minus 1 to 4 they suggest about the different categories of the reduced reflexes. Plus 1 to 4, they suggest about the increased reflexes, and usually they are drawn on a picture like this. This is a usual picture, and each of these reflexes are noted in terms of these numbers. This is how a neurological case sheet is written in a methodical fashion. So, of course, in a routine clinical practice, you may not draw this diagram, but it's better to have that kind of a habit. Like in neurological cases, when you study the reflexes, they should be recorded, which could be useful for assessing the maybe course of the disease later on in future also. So we can compare these pictures. So that's a standard method of recording of the reflexes as such. The reflexes again would be suggestive of involvement of the specific spinal nerve roots. Biceps reflexes usually suggestive of involvement of the C5 and C6. Brachyradialis is C6, triceps is T7, patellar L2 to 4, Achilles S1. These are the groups of the muscles and the segments of spinal segments which are involved in that. Which type of the involvement and how it has to be interpreted, more of that we will discuss later on. So that's about the study of motor activity. Then the next part is clinical examination of a neurological patient is to identify the cerebellar signs. Cerebellar signs are a group of symptoms or signs which are seen in patients with the involvement of the extrapyramidal tract or cerebellar pathology, or these also often named as extrapyramidal signs. Many times cerebellar or extrapyramidal signs, and they are ataxia, atonia, asthenia. These are also called as a classic triad of cerebellar signs. Tremors, which could be intention tremors that increase on activity, or dysynergy where there is a incoordination. Dysmetria is overshooting or undershooting where the patient is not able to control the movement at the proper level. Dysrhythmia where the repetition of a movement in a rhythmic tap is not possible, rhythmic pattern is not possible. Dysrhydokinesis is a difficulty in rapid alternating movements, difficulty with the rapid movements which tend to change as such. Dysarthria is speech affected. Like now, these words they look bit tough, but there is nothing very difficult there. It's only about the correct interpretation of these words should be clearly understood, and they should be examined properly. And the usual signs in as such would be the eye movements, which are oculomotor signs, also are the signs which are seen. Patients who may have an improper balance, when you look at the patient, you can identify a patient with extrapyramidal tract pathology easily. There could be a tremor seen, the patient may have a walking abnormality, there could be gait abnormality, forward bending, and then accelerating the movement. Fine skills may be deteriorated. Patient may not be able to write, pick, and so on small objects. Of course, there could be a cardiac problems occasionally, but that's seen later on. Then patient is not able to maintain the balance and coordination. Now, what we mean by these words are asthenia is a generalized physical weakness or lack of energy. Feeling tiredness is the asthenia, where the patient feels like sitting and maybe yawning or not interested in the issue surroundings as such. Sitting in the classroom with a yawning is a asthenia. Intense tremors is when a patient attempts to do a specific work, the smooth movement would not be smooth. That's what we call as intense tremors. Non-intentional tremors are tremors which are continuously persisting even in the resting condition. Intentional tremors can be better elicited by giving a patient a specific task like draw a circle. A normal person would have that circular movements of this sort, whereas a patient with a tremor, he may not be able to draw the circle like this. Instead, the pattern could be of this arrhythmic pattern, like an irregular shape could occur, so on. So it may be any task which can be given. Fine task like writing the name also can be given, and that can be assessed about the intentional tremors. Dysynergia is when the patient is not able to have a synergistic activity. If you ask the patient to clap, the patient may not be able to continuously clap one or instead of clapping in the proper manner with the hands in a plantar and this palmary and dorsiflexor pattern alternatively. He may not be able to do that in a proper manner. Or the other usual tests are done. Ask the patient to touch the nose by closing the eyes. So if the patient is not able to touch the nose when the eyes are closed, that also is sign considered as a extrapyramidal sign or a cerebellar sign. Or the other cerebellar signs could be tests which are often done would be you ask the patient to touch the finger, your finger, examiner's finger accurately from a distance. If your patient is normal, there will be a smooth movement to touch it. If there is a vibration, the patient is not able to touch it smoothly. Instead, it's just having wavering. Or if you ask the patient to clap as a instead of that, there cannot be a proper rotation. Or it could be like asking the patient with the rhythmic movement of the foot, which again can produce a alternate movement, not the normal. See, a rhythmic movement of the foot up and down of both the legs is a normal rhythm may be affected. Or it could be like these are the obvious signs which could be done. So tests of these sorts, different sorts, you may have some more planning of the test which is suitable for the patient, condition of the patient, considering the condition of the patient and considering the ability of the patient to grasp your orders. You may do any of these tests to confirm whether there is a cerebellar sign or not. So that's about one more of the clinical test. The another of the part of the clinical test of a neurological examination would be test for meningeal irritation. The test for meningeal irritation is the rigidity at the neck. Neck rigidity is the major sign, or it's also called as Kernig sign. And they could be of two patterns. Like one is when you flex the neck. In a normal situation, there will be no movement of the knee, but in a patient with the meningeal irritation, the knee tends to become flexed. Or the other way, if you flex the knee and then extend the ankle area, there could be a extension of the neck. So both these signs, like either it could be initially flexion of the neck and looking at the flexion of the knee, or it could be flexion of the knee and looking at the extension of the neck. So or flexion of the neck would be seen. These are called as meningeal irritation signs. These are also meningeal signs, and these are about the examination of the nervous system, basic examination of the nervous system. Basic examination of the nervous system also involves a system survey. System survey in the sense the whole system. It's not about all that whatever we have discussed till now is about study of either a few of the individual nerves or a group of the nerves or a certain part of the body related to the nerve and maybe a specific nerve function. But system survey is generalized involvement of the nervous system, like autonomic nervous system and neurovascular systems, like blood vessels and their abnormalities related to the nervous system also have to be examined. Autonomic dysfunction could be presented as symptoms like sweating, abnormalities of sweating, either excess or absence of the sweating. Temperature of the body also can be related to the abnormality of the nervous system, which of the conditions and so on we'll discuss later on. See, normally the thermal regulation is done by the central nervous system, and the temperature could be reduced due to many reasons, involvement of the thermal regulated system. A basic or a primary involvement of the nervous system also can produce the temperature variation, and that's a sign of abnormal autonomic nervous function. Cyanosis or pallor also could be seen as autonomic nervous system function, though it is usually categorized as cardiac sign. Trophic changes of the skin or nails, like ulcers which are produced, also can be a sign of involvement of the nervous system. Postural changes in the blood pressure. Now, all these signs can also be a sign of involvement of the other systems of the body, but a patient with the nervous system conditions also have to be examined, which could be due to a combined effect of the damage to the nervous system as well as the other systems involved. A postural changes in the blood pressure could occur due to loss of blood, or it could also be due to autonomic abnormality. Now, this has to be differentiated based upon the clinical evidences, other history and clinical evidences. But a patient of nervous system conditions has to be examined and to confirm like whether there is an involvement of the autonomic nervous system or not. Similarly, another of the important condition which we have to rule out is the involvement of the blood vessels and the blood supply to the periphery, like assessment of the brachial plexus and blood pressure. Blood pressures on both the sides, or the pulses, different pulses at the area, absence or presence of the arterial grooves, which are primarily the methods of examination related to the cardiovascular system, they also may be reflected about the abnormality of the nervous system. That's all the point. The point is, when we say examination of the nervous system, it's not that exclusively those tests which we have discussed till now are the complete examination. You also have to have a total approach to the physical condition of the body and confirm, like then the neurocutaneous systems, like there could be many of the diseases related to the nervous system which could be presented with the signs of the skin, like a sclerosis, tuberous sclerosis, which could occur in the skin over, and the skin may become rough, and there could be even loss of pigmentation over the areas, as in case of leprosy-like conditions, loss of sensation, and maybe the pigmentation also could occur, which is a primarily neurological pathology. Herpes zoster, where there could be eruptions at a specific segment of the nerves. Neurofibromatosis, where the nerve endings would be having a fibrous mass, and then it may be seen as this lesions over the surface of the body. So examination of these also are important. That's about the examination of the nervous system in brief as such. Now, in neurological examination, or neurological examination looks bit too complicated, or often students feel difficult because of some very complex words and a lot of other specific signs which are saying, and these signs also are called as ancillary signs. Now, my purpose of dealing with these now would be just to make you get acquainted with these signs and what are these signs elicited. The pathological interpretation of these signs is another part which we will deal with later on when we discuss individual diseases. So I will not go into that part of the pathological interpretation now. The whole idea of discussing these issues is now to make you acquainted with these words and how to identify these in the patients. Now, anisocoria is one specific word, and of course in the neurological conditions, examination of the eyes with the different aspects is one of the most important aspect of the clinical examination, and many of those signs could be suggestive of either a specific pathology, or at times they may have some non-specific evidence of involvement of the nerves, and they may help in making the diagnosis ultimately. So these could be ancillary signs. You may not be able to make a diagnosis based upon these signs alone, but these can help you to make the diagnosis based upon other pictures in the patient, other evidences of the patient. At times, some of these could be classic signs of a specific disease, and there are a lot of them, huge number of them, and there are many complex, difficult words used there. But I try to make out these as simple as possible and minimize them to the essential details. We are not going to all that. So whole neurological ancillary signs list is quite huge, so I will not go into all that. Among them, anisocoria is one word. Anisocoria means there is a asymmetry of the pupils. Pupils asymmetry, which could be of different patterns, like now, and when you have a situation where one of the pupil is closed, constricted, and the other pupil is dilated, and both of them are not reacting to the pupils similarly, and at the same time there is an abnormality of the movement of the upper eyebrow. The upper eyebrow is not able to contract in on one side, and the pupils are constricted. That's called as a Horner's syndrome, which could be an evidence of compression of the cervical ganglions, which are related to the sympathetic. Now, that sympathetic lesions, where the lesions would be, and so on, what are the different lesions can produce Horner's syndrome, we will be discussing later on when we go into the disease. A similar situation where the pupils are unequal in size, and when you expose the light, there would be an unequal response. Of course, when the pupils do not respond to the eyes light as such. See, when you put the light, normally the pupils will be constricting, and if this is also called as light reflex, and if they do not respond, or if the pupils do not constrict when the patient is asked to look at a near object, that's called as Argyll-Robertson's pupil. Now again, the point of in which condition Argyll-Robertson pupil would occur and how to interpret it, we will discuss later on when we go into the disease. So for the present, I will just limit to naming those conditions and how they are elicited. That's the only component which we'll discuss now. So Argent-Robertson people is a situation where there will be a abnormal light reaction to the light, as well as the accommodation reflexes, like when the patient is asked to look at the object from one side distance to the proximal side, is not, the pupils are not constricted. Then there is a Kogan sign. Kogan sign is where the patient is is not able to close the eyes properly, and whenever the patient is able to attempts to open the eyes, initially the major portion of the sclera becomes visible. It's drooping like eyelids. Either patient always prefer to keep the eyes closed, and when you ask the patient to look down, the position would be like initially a large area of the sclera would be visible, and that white portion would be visible. Then the eyeballs would be moving downwards, and this is usually sign of myasthenia gravis. What is myasthenia gravis and how this occurs is another part which we will discuss later on. But Kogan sign is a situation where the eyes will be drooping and eyeballs movement would be having a typical pattern where the cornea is not visible initially, sclera is visible, then the cornea becomes visible. Then Dalrymple sign is when the patient is asked to open close the eyes or open the eyes, the upper lid is not able to contract fully, upper lid becomes retracted more, and it could be of any degrees. Upper lid could be completely covered or it could be mild, which is usually suggestive of a thyroid pathology. Of course, that part is not the point now. The point is the opening of the eyes would result in upper lid becoming retracted, looking upwards, as you see on this picture. Like it becomes contracted, thickened, and the upper lid becomes somewhat more reflected. Like the under surface of the upper eyelid is seen. That's what we call as a lid retraction or a Dalrymple sign, which could be of different degrees. So that's the one. Or heterochromia iridis is another of the condition where the color of the eye would be different. That their color would be up to different pattern of iris. It could be like both the eyes may have a color, abnormal color, or maybe one color, one of the eye would have a dark color and the other may be light color. Or central is when a central portion of the eyes would show that difference in the color. Some areas in the one eye, the central area is dark, and the other eye, the central area is light. Or sectoral heterochromia, where a part of the eyeball sclera part of the cornea may show a darker color, and on the other side the color could be lighter, so on. So variations could be produced, and the color would be usually varying between blue and green, and it could be a sign of either injury to the iris or due to deposition of the metabolic substances. Another of the deposition pathology which can be seen in the eyes is a Kaiser-Fleischer ring. Kaiser-Fleischer ring is a ring around the eyes in the limbus cornea, around that, which is usually a brown colored appearance due to deposition of the copper, which is a very classical sign of the Wilson's disease, which is again a neurological pathology. Wilson's disease is a hepatolenticular degeneration, where there would be a degeneration in the lenticular system, lenticular nucleus, with the involvement of the liver, and there the Kaiser-Fleischer ring is a classical ring. Then Dole's eye maneuver is assessing the eye reflexes by turning the head in an unconscious patient, particularly in unconscious patient, and by looking at the eyeball as you turn the head to a side, or you give a stimulus with the cold water to the ears. And this is mainly done in unconscious patients, not in the conscious patients. Dole's eye maneuver is done in the unconscious patient to assess whether the brain stem lesion is there or not. If the brain stem is intact, when you turn the head to a side in a partial unconscious patient, eyeballs will try to maintain the position. It will not twist as such. In the patient with a brain stem injury, eyeballs would move along with the position of the head. As you turn to a side, eyeballs also, that focus of the eyeballs also will be moving to the same side and otherwise. Patient is not able to focus on one side. Or similarly, when you apply cold water, when you apply cold water in the normal person or a patient who has a normal brain stem but is unconscious, the eyeballs would be moving towards the side where you have put in the cold. Whereas in the persons who have an abnormality of the brain stem, eyeballs would not move to the cold response. If you put cold water to the ear on one side or touch a cold subject over the lateral surface of the face, eyeballs would not move to the same side. That's called as doll's eye abnormality. Then Marcus gun pupil is a paradoxical pupillary reflex. Normally, the pupillary reflexes would be when you expose the light to the pupils would constrict, and when you withdraw the light, pupils would dilate. But in patients with the abnormality of the responses, reflexes, there could be the other way. When you expose the light, the pupils may show a sudden dilatation, rapid dilatation. Then again there could be constriction. So the moment the light is exposed, there is initially dilatation and then maybe a partial constriction. That's what we call as the Marcus gun pupil or paradoxical pupillary reflexes, and it also is better observed when you swing the light across the eyeball. So it's not just exposing. If you swing the light as such, it's seen that the pupillary sizes would be having a paradoxical contraction. In the resting condition, everything may look normal. That's called as Marcus gun pupil. Then medius sign is refers to a weakness of ocular convergence. Like in a normal person, when you ask the patient to focus on an object which is close by, you bring a finger from the distance and bring it close to the eyes, there will be a convergence. Eyeballs will move towards the medial side. But in the patients with the abnormal ophthalmic pathologies, ophthalmic malfunction, particularly this is seen in case of thyroid abnormality like Graves' disease, the focusing is not possible. The eyeballs would not converge. The patient is able to see, but eyeballs would not converge. That's called as a medius sign, which is also a sign of thyrotoxicosis. Then Mersenne sign is usually seen in patients of Parkinson's disease. Now it's also called as glabular tap. Glabular tap, which we consider as a primary reflex activity. In a child, when you touch upon the glabular area, eyes will be closed. But in an adult, this doesn't. But in a patient with Parkinson's or extrapyramidal tract lesion, this is one of the signs. As you touch the forehead or just hit the forehead with just a soft touch, the eyes will be closed, and this suggests of abnormality of the frontal lobe, usually in Parkinson's disease. Then there is another called as Summerskill sign. This refers to bilateral upper and lower lid retraction. See, upper lid retraction we have already referred to. Both upper lid retraction as lower lid retraction could occur, and this is very common in case of a hepatic pathology. Neurological manifestations of the hepatic failure, chronic hepatic failure. This is one of the signs, Summerskill sign as such. Then one grave sign is a failure of the upper eye to follow the downward movement of eyeball when the patient changes his or her vision from looking up to downwards. The eyeballs would not be moving downwards as such, and these palpebrae, they tend to cover up the area, and upper eyelid particularly would not be able to open and close properly. That's called as one grave sign, which also is a sign of neurological pathology. Then there is an word opsoclonus. Opsoclonus is a large amplitude, sudden movements, oscillations of the eyeball in all directions when you attempt to change the focus. When you ask the patient to look at an object at distance and then again bring it to the near side, there could be a sudden large amplitude, rapid movements in all directions, which is slightly different from what we call as the nystagmus. So opsoclonus is again a sign of extrapyramidal tract involvement. Whereas optokinetic nystagmus or simple nystagmus is elicited better by asking the patient to object over focusing on a striped drum or a moving cloth, so that the patient would be focusing on one area, line like. It could be rotated or it could be moving cloth, and then look at the eyeball movement. The eyeball movement could be having a nystagmus, which could be either in lateral direction, side to side, or upward to downward, or they may be circular. So opsoclonus and nystagmus, these two are slightly different. In obstruclonus, there will be rapid movement in all directions. Nystagmus, there could be specific directional orientation, either side to side or upward downwards or circular movements. That's called as the nystagmus, optokinetic nystagmus as such could be seen. Then another is the Steinbach sign. This refers to decreased blinking activity and particularly thyroid abnormality. Normally, your eyeballs would be blinking at certain specific intervals, and if the eyeballs fail to blink at regular intervals, there is a delay in the blinking, which also can be a cause for the irritation of the sclera later on. That's called as a Steinbach sign. That's about some of the eye signs. We will continue in the next session with the other signs, and if there are any questions, I will try to answer, and then we'll continue next slide. So we will wind up today. There are no questions, and we'll continue in the other signs, ancillary signs, other ancillary signs.